All right, good morning. We're going to get started on session 3, Divergent Histology in Kidney Cancer. I'll give you guys a chance to get back to your seats. It's a pleasure to introduce today's distinguished panelists, each of whom has made remarkable contributions to the field of kidney cancer research and treatment. First, we have Dr. Elizabeth Henske. She is a highly esteemed researcher and physician known for her pioneering work in the genetics of kidney cancer and rare tumor syndromes, including tuberous sclerosis. As a professor at Harvard and director of the Center for the Lamb Research and Clinical Care, her groundbreaking research continues to shed light on critical pathways and therapeutic targets. Please welcome Dr. Henske.
Thank you very much. I'm super excited to be here to tell you about what we're working on right now in the chromophobe kidney cancer area, and I'm going to be sharing primarily unpublished work. I want to start by just acknowledging the really amazing people I feel so privileged to work with in Boston and beyond, including many people who are here today, including David Braun and Vincent Zhu and 4 members of my lab. And also to mention that Carmen Priolo is my collaborator on everything we do in chromophobe. So chromophobe, as you know, represents about 5% of all kidney cancers and is characterized by these large polygonal cells with abundant pale cytoplasm. I'm going to be telling you about 2 new potential therapeutic targets. One is ferroptosis suppressor protein 1 and work done by Samer Salem, who's here today, and the second is BCL-XL and work done by Nadine Mahmoud. So chromophobe RCC arises from these super interesting intercalated cells in the distal nephron that are very abundant in mitochondria. And as you probably know, chromophobes are distinctive because they have very few genetic drivers. P53 mutations in about a third, some mutations in the PI3 kinase pathway in another 10 or 20%, but about 50% do not have a driver. And in those cases, we think that mitochondrial mutations and ROS may be the driver, but that remains to be seen. We had found in a prior set of studies that glutathione levels are really, really high in chromophobe kidney tumors, and at first we thought that might mean that the tumors were resistant to oxidative stress, but in fact these chromophobe tumors seem to be more sensitive to ROS stress, leading to ferroptotic cell death. So previously we were focusing primarily on this arm of ferroptosis suppression involving the transporter SLC7A11 and GPX4, but the work I'll share with you today is focused on another arm, which is FSP1 or ferroptosis suppressor protein 1, which reduces coenzyme Q, also called ubiquinone. And we found that the levels of FSP1 are about 2-fold higher in the TCGA and chromophobe compared to matched normal kidney. So this is work that Samer Salem did, where he found that knockdown of FSP1, shown here, sensitizes UOK276 tumor cells to ferroptosis caused by inhibition of GPX4. So here is SI for GPX4. We didn't see very much effect of SI for GPX4 alone or SI for FSP1 alone, but the combination has a profound effect, and that's rescued by the ferroptosis suppressor drug ferrostatin 1. And we see similar results with a second cell line called RCJ-T2 that were developed by Tai Ho at the Mayo Clinic. These were genetic knockdown experiments. Next, Samer asked whether there could be synergy with pharmacologic inhibitors of FSP1. So he used FSEN1, which is an inhibitor of FSP1, and RSL3, which is an inhibitor of GPX4. And what you're seeing here is the synergy at a single dose. He tested about 30 doses altogether, but you're seeing synergy here just as an example at 1 dose where there's little effect of RSL3 or FSEN alone, but the combination has a marked effect on the viability of these cells. We see similar results in the other cell line, UOK276, and this seems to be a quite different landscape of these 2 drugs with the clear cell 7860 derived cells. So the conclusion from this first part is that ferroptosis suppressor protein 1, or FSP1, is upregulated in chromophobe RCC. FSP1's role is to reduce the antioxidant coenzyme Q, also called ubiquinol, and there is synergy, both genetically and pharmacologically, of inhibiting GPX4 together with inhibition of FSP1. So next I'll talk about unpublished work from Nadine Mahmood, and I would just mention that both of these stories I'm presenting for the first time today, so bear with me if I stumble a bit. So this is work that arose from a screen we did with Chris Sarosiak at the Harvard School of Public Health, and we've also discussed this project with Abhishek and gotten some really great advice from him. So this involves BH3 profiling. So BH3 profiling is a way to take cells and figure out which pro-survival proteins, BH3 domain proteins, are critical. I also work on bird hog debate, so I have a typo here of BHD, not BH3. So you start with your cell lines, in this case chromophobe, you permeabilize the membrane, and then you administer BH3 mimetics that are specific for different members of the BCL2 family. Then these mimetics will inhibit the members of the BCL2 family, and then you can assess which ones have the biggest effect by looking at cytochrome C release. So the screen that Chris Sarosiak has involves about 8 different pro-apoptotic peptides, each of which inhibits different members of the BCL2 family. So these are the results in the UOK276 cells, and over here, just as a reminder, is what each of these peptides inhibits. So the effect, these first ones inhibit so broadly that we do see a dose effect, but don't really provide specificity. But HRK and MS1 specifically inhibit BCL-XL and MCL1, and there we saw a excellent effect at the higher dose and a clear dose effect. And in the RCJ cells, we again see that HRK has a very nice profile with a lot of induction of apoptosis at the highest dose. So we then looked at back to the TCGA at all of these proteins and found that BCL2L1, which encodes BCL-XL, is more than 2-fold upregulated in the chromophobes compared to matched normal kidney. We also found, or Nadine found, that knockdown of BCL-XL in the UOK276 cells and in the RCJ-T2 cells increases cleaved PARP, shown here for the UOK cells and shown here for the RCJ cells, and inhibits cell viability, suggesting that these BCL-XL is important for the survival of the cells. I mentioned that UOK276 cells seem to have activity of MCL1 also, and we have found synergy between inhibition of BCL-XL and MCL1, and that's shown here, again done at multiple doses, but here's just one dose as an example. Not very much effect of BCL-XL alone or the MCL1 alone, but a nice result in combination, and this is the UOK276 and the RCJ-T2 cells. We were, of course, always interested in ferroptosis, and it does appear to be a synergistic effect between the apoptotic cascade and the ferroptotic cascade in these chromophobe-derived cells. So here, for example, are the UOK276 cells treated with the BCL-XL inhibitor, the MCL1 inhibitor, or the combination of those two drugs with the ferroptosis inducer, RSL3. And here again is a similar result, but in this case we're using the ferroptosis inducer IKE, which inhibits cysteine import, and which we've used extensively in other studies related to chromophobe. So just to sum up, this is my last slide. We're interested in identifying therapeutic opportunities in chromophobe, and these unpublished data indicate that there is further that we could go with the ferroptotic cascade by targeting ferroptosis suppressor protein 1. FSP1 was only really characterized just in the past 5 years, so there are efforts to identify pharmaceutical suppressors of this. And what we're seeing is that FSP1 inhibition synergizes with GPX4 inhibition. And then secondly, in terms of apoptosis, BCL2L1, which encodes BCLXL, is upregulated about more than twofold in chromophobe. Inhibiting it induces apoptosis in chromophobe, and we're seeing synergy between apoptotic inhibitors and ferroptosis inducers in the context of chromophobe kidney cancer. So it definitely takes a big group to move forward in a disease like chromophobe. I'm so grateful to so many of you in the audience for really bending over backwards to be helpful, and I'm hoping that together we can move things forward for individuals who are living with chromophobe kidney cancer. Thank you very much. I guess we have time for questions if there are any questions at this point. Yes, Celeste.
So, now you can hear me, sorry. I was just wondering if the chromophobe cells are sensitized to ferroptosis, because if you look at, for example, proteomics, they lack some of the most robust gatekeepers. Or do you think their baseline lipid content means they're more likely to get peroxidized, or do you think it's a combination of the two?
Yeah, that's a very interesting question. We do think that the enzyme GGT1 gamma-glutamyl transferase, which I know you've also looked at in clear cell, is markedly low in chromophobe, so that may be one factor. We also think mitochondrial stress is high. These cells are very mitochondrial abundant, and that is because they have this very important, the normal intercalated cell has this very important job of maintaining body pH by excreting hydrogen ions into the urinary space. So we think they're at high risk for mitochondrial-induced ROS damage. And then there are almost certainly other factors that are contributing. So, you know, it's known that clear cell tumors seem to be among the highest susceptibility to ferroptosis, and chromophobe seems to be even higher than that.
Oh, wow. Okay, great. Thanks.
There will be time for more questions at the end. Thank you.
Next, we'll have Dr. Yingbei Chen, prominent pathologist at Memorial Sloan Kettering, where her expertise lies in renal tumor pathology, with a particular focus on molecular diagnostics and how they guide precision medicine. Her work is instrumental in developing more accurate diagnoses and tailored treatments for our kidney cancer patients. Thank you, Dr. Chen.
Thanks for that kind introduction, and thanks for the opportunity to speak here. So today I would like to briefly review the histologic and molecular definitions of divergent histology in the current WHO classification, and hopefully to highlight some of the diagnostic challenges we are facing every day and some of the knowledge gaps still existing. So in the 2022 WHO renal cell tumor classification, so there's some structural changes. One particular thing is there's a now separate molecular defined RCC sections to highlight the entities that really require specific molecular alterations to really pinpoint the classification. So this is sort of like separate from the more morphological defined groups we had before. Not saying those groups don't have specific molecular alterations, but there's inherent challenges because molecular defined RCC often have a much broader spectrum. It doesn't fit nicely with any of the previous group we had. And also we had, for the morphological groups, highlighted here. So we have this newer oncocytic neoplasm group to include some of the emerging entities, and other oncocytic tumors were still not capable of clarify their biology or difference from oncocytoma. And so let's dive in this long list. So before talking about all the non-clear cells, so I just want to highlight for clear cell, especially for the high-grade cases, the morphology really harbors such a broad spectrum. So in small biopsies, when we only see a sarcomatoid differentiation or some really completely different morphology, it's very challenging to pinch a very specific diagnosis on the core biopsy before you're giving systematic treatment, especially at some of the metastatic sites. So we do have some markers. For example, CA9 would, diffuse membrane staining would highlight is most likely to be a clear cell renal cell carcinoma. But when they become sarcomatoid or other morphology, this staining pattern could lose. It also can lose PAX8, so we don't even have a primary site clue. So as resection, so you could see some of the histologic subtyping change compared to what you had from the biopsy. So now focusing on the non-clear cell or the divergent histology we typically use in the clinical setting. So from morphological spectrum, we usually approach them based on architecture patterns and then in combination with cytological features. So papillary RCC is the most common divergent histology you would encounter. Go back. Okay. So, but there's many molecular defined entities have prominent papillary architecture that could hinder our diagnosis. So quickly going through some of this. So the translocation RCC now has slightly altered name. So we specify it's either called TFE3 or rearranged RCC, characterized by various TFE3 fusion occurring with different partners. And then in this group, you also have the TFEB rearranged RCC. And we have a small improved understanding of some of these tumors are actually TFEB amplified RCC. So instead of having characterization, why is it going by itself? So it's actually characterized by a 6p21 amplification. A small subset of this may have co-occurred TFEB rearrangement. So all these findings, because we do have diagnostic tools, we use FISH, we use NGS analysis, so this helps us to actually understand there's this slightly different group of TFEB altered tumors. So now the WHO decided to change the name to the TFEB altered RCC to expand the morphological spectrum. All these tumors could have prominent papillary architecture, and for the amplifier, you could even have oncocytic high-grade morphology. So FH deficient RCC is another group of high-grade papillary tumors that and also can show many other architecture patterns. So it's a mimicker of, for example, collecting duct, and can even show a low-grade oncocytic morphology in a small subset of cases. And diagnostically, we rely on some neuromarkers such as 2SC and FH to help us specify this diagnosis. And the genetic counseling and subsequent sequencing would help us to identify or support whether it's a familial syndrome or it's sporadic cases. Another translocation RCC is a newcomer to the WHO classification. This is mediated by the ALK fusion. This is still something we're understanding because some of the cases have more unusual, unclassified morphology, suggesting ALK did, underlying as a driver mutation for those group of tumors. But other tumors can mimic the previous known papillary or MTSC or metanephric adenoma, suggesting ALK may be also another mechanism to mediate some of the known morphological subtypes. So going back to papillary RCC, so the main thing happens is now we're relying on excluding all those molecular entities to really going back to the more traditional papillary RCC diagnosis. So the reasons why the subclassification into type 1 and type 2 no longer recommended, because a few reasons. First of all, as I just shown, there are many, the previous called type 2 RCCs actually historically include the molecular defined entities. So if you exclude those cases, in the recent large papillary RCC cohorts, you see the typing lose its prognostic value, while the grade still maintains some level of correlation with outcome. And particularly also in PRCC, there are many cases that actually have mixed type 1 and type 2 features. By doing molecular analysis, the evidence suggesting they represent either clonal evolution or morphological deviance. So here is like two examples I'm showing you. In the same tumor, you have the more classic type 1 morphology on the left side of each case. And then on the right side, you have the higher grade, morphologically fitting with type 2 description that actually have very similar, some of the initial driver mutations, but then may gain additional later events that maybe explain this higher grade morphology. So now we know that a high grade, so-called type 1 actually could have high grade features that, exactly is type 2. So, you don't want to call one tumor as 2 types. So that's another reasons, the typing is no longer applicable for many of the cases. So when you're going back to look at the TCGA spectrum, you can see on the top, some of the, if you look at the PRCC type 2, you can see a lot of them share the similar copy number alterations as the classical type 1. But there are some, others are not showing that pathology. So the question is, what are those tumors, and whether they should be maintained as part of papillary, or we should look further for other things. In the TCGA study, some of them maybe have, some of them may have the more increased, like for example, Hippo pathway or NF2 pathway activation. So another unanswered question is, so where you draw the line with papillary versus unclassified? Now everything depending on excluding other diagnoses. So in our practice, we are really relying on if we see very complex architecture pattern, and papillary is only one part of it, and there's the tumor lacking any classical papillary morphology, then we say we would maybe favor is more like an unclassified tumor rather than a known papillary. So here is just a quick example to show you how we approach this. So there's the first case. So it shows some unusual features for a papillary. For example, it has this very infiltrating border as a peripheral, which you don't really commonly see for papillary, and has a lot of macropapillary architecture. But focally, we do see the classical features of papillary as shown here, and then other areas showing the higher grade morphology. So for this, if you combine with other approach to exclude the molecular entities we mentioned, like for example, FH is retained, 2SE negative, it's not a translocation tumor, and we do molecular analysis, we see it has copy number still match with papillary, and it has somatic mutation of MET. So this would be probably a perfect example as a high-grade papillary to undergo treatment more targeting a papillary molecular alteration. On the other hand, this case also, is sort of infiltrating growth, and we don't, everywhere in this tumor is a similar cytological features as shown here, a tubular papillary high grade. It's not the typical papillary we'll see. So also it's not one of the molecular entities. So for now, we're still calling them unclassified, but it could be unclassified with a lot of papillary architecture. And then by molecular analysis, you can see they have more complex architecture pattern changes. And this one happened to have the NF2 mutation. So moving on to the high-grade poorly differentiated group. So here I just want to emphasize 2 entities. One is the renal medullary carcinoma. Now we're more specifically using SMARCB1 deficiency to define this entity, so the name slightly changed. And then the other is a collecting duct carcinoma. So the renal medullary carcinoma is familiar. So the main essential diagnosis criteria is a high-grade infiltrating adenocarcinoma that is SMARCB1 deficient. And desirable features, we want the patient to have clinical evidence of hemoglobinopathy. And for patients with this exactly morphological phenotype, but clinically without any hemoglobinopathy, so we call them SMARCB1 deficient RCC with medullary phenotype. I think this case right now seems clinically they are managed similarly as medullary carcinoma. On the other hand, there are rare cases of other high-grade RCC may have SMARCB1 mutation, and even a smaller subset even have protein loss, but they have other features. So in that setting, then SMARCB1 is not a specific molecular diagnosis marker. For collecting duct carcinoma, we run into a little bit similar problem as high-grade papillary, where the diagnosis depending on exclusion because there's no defining either morphological or molecular features to say this has to be a collecting duct carcinoma. A lot of diagnoses rely on the sort of a really medullary involvement and then really predominant tubular morphology and stromal reactions. And also right now, because of molecular entities, we do a lot of other studies to highlight that there's no those other additional criteria that would suggest other diagnosis in this setting. So moving on to the chromophobe, another very common divergent differentiation you would encounter. And so here we are a little bit luckier. So usually in the nephrectomy specimens, the diagnosis of a chromophobe is relatively straightforward because it has quite relatively straightforward morphological features. As shown here, the large pale cells sometimes intermixed with smaller eosinophilic cells. Sometimes the eosinophilic cells dominant. This is usually we use to call eosinophilic variant. And on the right-hand side, you see example of sarcomatoid differentiation that really sort of take over the tumor, but you can still see a little bit of the epithelial components left behind. The challenge here is a lot of times is at for the eosinophilic spectrum of the tumors because we have many other diagnoses of showing solid and eosinophilic phenotype. So this sort of translates into the biopsy setting. So, usually patient or clinician got disappointed because we cannot give a definitive diagnosis because we have very limited sampling. So a few important things in the differential of the eosinophilic spectrum of chromophobe, one of them is a relatively newer entity, the SDH deficient RCC. These have a germline implications, and majority of SDH RCC actually turn out to be a patient with a germline alteration. And most cases are low grade, but occasionally you encounter a very aggressive case that where a large portion of the tumor undergone this more high grade transformation. And that's something also, rely on IHC to help us to recognize. And then there's other more indolent tumors, more happening in the other syndromic settings, such as PHD, or mediated by the germline flocculin gene mutation. They have also a vast spectrum of morphology, mixed cell. So this is something we're still not very capable of directly recognizing based on morphology when we're lacking a specific IHC or easy marker to allow that in the routine diagnosis. Tuberous sclerosis complex also, although the incidence is not that high, but various renal epithelial tumors can do occur in this setting. And there are in many patients, they are bilateral multiple. And interestingly, so that recognized that morphology has initiated a lot of recent studies identify sporadic tumors, also primarily driven by the TSC-mTOR complex 1 mutations. Some of the names, so they all become abbreviations: eosinophilic solid cystic, called ESC tumor, eosinophilic unvacuolated tumor, EVT, and low-grade oncocytic tumor. So we don't know why such spectrum is so broad, but they are all having most frequently TSC, TSC1, TSC2, mTOR, and in the case of LOT, maybe RHEB mutations. And I would say the most relevant one also, when we look at historic cases, are the LOT cases. Because of the paranuclear halo, you can see in this group. So many of these previously being called eosinophilic variant of chromophobe. So when we look at more closer at the molecular comparison of these two groups, you can see LOT is really dominant by mTOR, RHEB, and some other mTOR mutations, while a chromophobe is mainly a very rare TP53 and some other mutations. Their copy number pattern also differ. And we also think instead of arising from intercalated cells, the LOT most likely arising from principal cells of the distal tubules collecting duct. So additional, even after all this long list, we still cannot figure out some of the other tumors that mimic oncocytic renal oncocytoma, but have slightly more nuclear atypia. So, so that's pretty much the divergent in the non-clear setting. Now we have to move back. This is the last portion. So we still have some other variant, have the more clear cell type of morphology. One of them is now a newly molecular recognized entity called ELOC mutated RCC. So you can see they mainly have a nodular growth. And there's a descriptive term that's not really official recognized by WHO. It's called RCC with fibromyomatous stroma. So summarize this ELOC, or some of them are TSC, mTOR mutated tumors. They have clear cell cytology, but they often have some unusual architecture patterns compared to clear cell. Whether they should be managed more like a clear cell versus non-clear cell is unclear, but most of these cases are relatively indolent. So I think for the systemic setting, it's not a big issue yet. So just highlight some of the knowledge gap. For papillary, mainly the high-grade spectrum is not well defined. For collecting duct, we're also lacking defining features. And for the chromophobe and for many of the oncocytic tumors, we need to know more about what's deciding their prognostic features and know more about their biology. And take-home message, I just want to emphasize saying the WHO classification of divergent histology really depending on integrated understanding of histomorphology and molecular features. And the high-grade RCC with either papillary or fully differential morphology is very challenging and rely on the exclusion of the molecular defined entities. Thank you.
Thank you, Dr. Chen. It's amazing how this gets more complex every year. We're going to hold questions in the interest of time. Up next is Dr. Bradley McGregor, a medical oncologist from Dana-Farber Cancer Institute, talking to us about treatment options for divergent histology. Thanks, Brad.
All right. So yeah, thank you to the organizing committee for the opportunity to be speaking with you today. So I've been tasked with talking about treatment options for divergent histologies in under 10 minutes. So buckle up, because we're going to have to go fast. So learning objectives, understand the current data for combination therapy in the renal cell carcinoma divergent histologies, and understand how can maybe all this information we learn from the pathologist sort of actually help us to find a different systemic therapy for different histologies. So as we just heard, this is no longer non-clear cell renal cell carcinoma. We have so much more information from the pathologist now than when this first started out. And that's why we've sort of moved away from this. It's not just non-clear cell, right? Each histology is its own independent entity. And now as we get all this information from the pathologist, it's really up to us and everyone in this room to say, how can we use that information better to advance care for our patients? So there's a lot of earlier prospective trials that all look to beat up on everolimus and sunitinib, and so that was sort of considered the gold standard. But fortunately, we have a lot more data since then, where I would argue that sunitinib is no longer the standard for our patients with metastatic divergent histology renal cell carcinoma. Starting with PATMET, which was presented by Monty now a couple of years ago. I mean, this was a pivotal trial, the first trial in the randomized setting to say, hey, let's look at sunitinib versus different options, right? And so the idea was that papillary RCC we just heard about, if this should be MET driven. So let's look at all these different MET inhibitors. And I think when we see at this trial what happened is what we just heard about from pathology is that not all papillary is the same. So this idea that there's type 2 papillary, that they're the same as type 1, they're different entities. And subsequently, as the trial was going on, the very specific MET inhibitors were closed for futility, and it was left to look at sunitinib versus cabozantinib. We've seen the data before. There's an improvement in progression-free survival with cabo versus Sutent, improvement in objective response rate, and a trend towards a benefit in overall survival. So this really was a positive trial. It led to the advent of cabozantinib is now a standard in care for patients with papillary RCC. But it shed some insight into that not all papillary are the same. And so that was the idea behind Savoir. Savoir said, listen, we're not just going to look at papillary histology, we're going to say, we're going to go beyond what the slides look and look at the genomics, right? And so we're going to say, idea is that if we have a MET alteration, we should be able to do a very clean drug and a very potent MET inhibitor. So this trial required central confirmation of a MET-driven tumor, either chromosome 7 gain, MET or HGF amplification, or a MET kinase domain mutation, randomized the patients to savolitinib or sunitinib. The trial was closed early for a lot of statistical reasons, thinking that sunitinib may be doing better than they thought it would. But ultimately, I think what this trial showed is that we could do this trial. So this trial said we're going to take patients with genomic alterations, and they accrued patients. I think that is remarkable. It shows us that when we work together as a community, we can do these things. It's small numbers, just around 60 patients, but improved objective response rate with savolitinib versus sunitinib. But there's also early data that said, hey, if we add durvalumab, that response rate jumps up to 60%. And so that is the basis for the ongoing SUMMATA trial, which I think you'll probably hear about, but I think it's reaching its accrual goal, and which you should hear more about from Dr. Mon. So again, going on the idea that not all papillary are the same, what about like FH deficient RCC? This is something that historically been associated with a very poor outcome. We saw really exciting data from the NCI where those patients had papillary RCC, but predominantly those patients who had the FH deficient RCC, there was a clear benefit to bev/erlotinib with objective response rate of 72%. And we can see that progression-free survival, 21 months in that subset of patients. So already we can start saying, well, for those patients MET-driven, we should look at these MET-driven trials. For someone like FH deficient RCC, I think bev/erlotinib certainly has a role and is one of the options we should be pursuing. What about other, VEGF combinations? I think lenvatinib everolimus, this is, approved for clear cell in the second-line setting. There was a trial in the frontline setting for divergent histologies. Overall, I think we'd agree it was relatively disappointing across histologies, but there was a really encouraging signal for those patients with chromophobe RCC. Granted, only 4 patients, but 4 of 9 patients responded with an objective response rate of over 40%. So this small trial, a cohort of 9 patients, is what has led everyone to say, oh, well, we should think about len-ev for our patients with chromophobe RCC. And it just highlights what we can do with small numbers in these rare diseases if we all work together and can collaborate. So in the second half, we'll talk about what is the role of immunotherapy. There's a lot of trials that are ongoing looking to expand upon this, but we have a lot of trials that have already been completed. So we've known for a while that immunotherapy has some efficacy in those patients with divergent histology, probably not quite as good as clear cell, but we have data from Dr. McDermott, a single-arm phase 2 trial looking at papillary chromophobe unclassified, and we see that there's certainly activity in this population, less so in chromophobe compared to the other groups, although, we had this whole big discussion yesterday. We shouldn't be looking at these forest plots, but I think there's a signal there overall that potentially, chromophobe, we thought in the science would support that it may be an immunologically cold tumor and the role of immunotherapy may not be as well defined. There was a hint that, PD-L1 status was predictive of benefit. And that was it. And then we had recently, I think, the one new trial that I think is the most interesting in the past year was Sunny Forecast. So this is a randomized trial that was conducted overseas and took patients with divergent histology who had not received any prior systemic therapy, and they were randomized in a 1-to-1 fashion to standard of care agents or Nivo/Ipi at the standard Checkmate 214 dosing. And the therapy was continued on progression, unacceptable toxicity. They chose a really unique endpoint, and they chose really well because that endpoint was positive, looking at the overall survival rate at 12 months. So who was enrolled in the trial? I think it's noteworthy. There was a lot of different histology enrolled. A majority of these were papillary, as would be expected, but 20%, so 60 patients were enrolled with chromophobe RCC. They had small number of patients with renal medullary, close to 20 patients with translocation, some sarcoma as well, but we had a wide array of histologies enrolled in this trial. And what we see is the trial did meet its primary endpoint for improving overall survival at 12 months, 87% versus 77%, while the overall survival rate is 6, 18 months, and the median sort of looked better. It actually was not statistically significant. So again, kudos to the investigators for picking the perfect endpoint. This is a median follow-up at 24 months. But breaking this down a little bit further, I think one of the interesting things is, well, does histology matter when we start looking at this overall? And I think what we see is that there was a benefit of nivo-ipi independent of histology. And I think notably, patients with chromophobe actually had a response to nivo-ipi with a 26% response rate, 7 patients. So I think that is something thought-provoking. I think it's something we need to look at. We need to see the paper, like try to see are there any tissue, things that we can say, why did this happen? This is different from what we've maybe seen before. In the last couple minutes, nivo-ipi, I think, small study, thought-provoking. What about the role of IO-TKI? So we have 2 different studies with IO-TKI, Cabo-Nivo, Len-Pembro. Cabo-Nivo was presented a while ago. We've had updates. I think this showed really good efficacy, around a 50% objective response rate overall in patients who had either first or second-line treatment. Really no genomics to help us figure out who is going to respond. Of note, this trial was designed with 2 different cohorts, the chromophobe and the non-chromophobe. And the chromophobe in the first 7 patients, there were no responses, although there were patients that had shrinkage of the tumors. And so we think about Cabo-Nivo really for those non-chromophobe histologies. And we see that here in the waterfall plot. Associated with mean PFS around 12 months, mean overall survival of 28 months. So I think single-arm phase 2 really supports the role of IO-TKI. And it's supported again by Len-Pembro data. So this is a very impressive waterfall plot presented by Laurence recently, showing that the combination lenvatinib and pembrolizumab has activity across the divergent histologies. Again, similar to what we saw before, around a 50% objective response rate. Notably, there was a pretty impressive response rate in the chromophobe, around 35%. So thought-provoking, the thought is maybe lenvatinib may be the key. That was my thought, and then we see the nivo-ipi data, and I get a little bit more confused. But I think we have a lot more to learn, but it really shows that it's activity of IO-TKI, as you see here when we look at the progression-free survival curve and the overall survival. Finally, yes, we can, but it's way too toxic at 40 milligrams with nivo-ipi, and it really, at that dose, is not ready to move forward. We have an ongoing cohort looking at 20 milligrams, and we hope to have data presented in the near future. So current state, there's a lot of activity for combinations, but clearly, these are all single-arm trials, and we look forward to the randomized data that will be generated from the ongoing trials. So take-home messages, I think combination therapies have high response rates in single-arm phase 2 trials. Future will be guided by ongoing novel therapeutic trial designs. And I think we can enroll patients in these trials. And as we sort of do these trials, we take all these histologies, it's really important to do the work after the trials accrued and look at these different histologies and try to use the science to determine which regimen will be right for each patient. And so that, I'd like to thank you for your attention.
Thank you, Dr. McGregor. Now we'll bring up Dr. Benjamin Mon from the Huntsman Cancer Institute.
Well, welcome everyone to this session and, well, the close of this session. This is such an amazing meeting. I'm just so grateful to be here and share this time with all of you. It's, this is really well put on by the KCA organization. So I've enjoyed coming here for the past number of years. So what are we focused on in the next 10 minutes? Really just exploring what are some of those ongoing clinical trials, and at least in terms of how I think about it, what are some of those lessons that we're learning from clinical trial design? So as I was thinking about this topic, the first thing that kind of popped to my mind was Sesame Street. So here we have Susan playing the iconic "One of These Things Does Not Belong" game from the pilot first episode. And so really, in this space of non-clear cell kidney cancer, it's kind of the opposite. One thing doesn't belong, which is clear cell kidney cancer, and everything else is sort of different or distinct. But this is how we used to think about this space of non-clear cell kidney cancer. I was reminded about one of the sessions that I attended at my first ESMO meeting. It was, I don't know, clinical data on Everest or something like that. I don't remember anymore, to be honest. But what I do remember is that Nizar stood up after the presentation, and he was talking about how we really need to shift our focus away from basket trials to disease-specific trials. And everyone was sort of grumbling, and it was going to be too much work, and we couldn't do it. But we have been successful in doing that, and I would argue it's made a tremendous impact in our scientific understanding of these diseases and in the lives of our patients. And the reason that it's important, I'm not going to go into any of these details here, I just decided to show up some fun splashy graphs, but the reason it's important is for all of the reasons that we've heard from the scientific sessions yesterday, from the earlier session, the talks in this session. These cancers have unique molecular drivers. They have unique pathologies, they have significant prognostic implications for our patients. And if that's true, or I should say because that's true, we should understand that there's going to be unique treatment patterns and paradigms for each one of these diseases. Sure, there are some shared molecular features between some of these cancers. You can find P53 alterations in some of them, but as a disease, there are a collection of unique molecular features. So as I think about the clinical trials, at least in terms of the ongoing studies, it sort of occurred to me that they really sort of functionally separate in terms of like ways we're trying to optimize our currently available therapies, or certainly new pathways that are available. And we certainly heard about some of those new pathways yesterday. Orange to the left is brighter just because that's where most of our effort has been to date. But there is a lot of new emerging clinical trials as well as laboratory science exploring new pathways. So if we look at a sort of curated or selected list of ongoing trials in the sort of optimized bucket, as I would call it, I've listed a few here. Again, this is not all trials. This is a selected list. For instance, as you can see, I've omitted all phase 1 studies from this list just to provide some clarity. But interesting to me, you can see a number of randomized practice-changing clinical trials as well as signal-finding trials. You can see single-arm studies more in the signal-finding range. You can see randomized studies. To echo a message that Brad was just telling us, I would strongly emphasize that we are following the charge that Nizar and others requested of us, that we really start focusing on each disease specifically. And so if you look at the far right column in the population, you can see that that is indeed what all of these trials are doing. Some of them are including a few, but not all diseases together. For instance, with Stellar 304, it includes papillary, unclassified, and translocation. But again, others include a variety or very specific diseases. So you may ask, since we already have these therapies available, why do we, we can do it, but it is hard to accomplish these trials. It requires a significant amount of resources and effort. Why do we need to focus on this? This really is echoing a message that you heard from Brad just a moment ago. But if you look at, this is a slide I just, for convenience, took from a similar talk I gave here last year. But if you look at the TKI-IO responses in metastatic papillary kidney cancer, you can see with like COSMIC-021, there's a 47% response rate. With KEYNOTE-B61, there's a 54% response rate, clearly demonstrating that these drugs have activity in this disease. But if you do sort of a envelope comparison and look at the response rates that we see in clear cell kidney cancer, these are less than we see in those cancers in patients. For instance, with KEYNOTE-B61, the objective response rate was over 70%. So these therapies clearly don't seem to be working as well in a number of these cancers. Here I'm highlighting papillary. Brad did a lot of effort highlighting chromophobe, but they don't seem to be as effective as they do in clear cell kidney cancer. That suggests to me that either we haven't figured out how to optimize the therapies, or these are not the optimal therapies for these patients. So there's clearly is room, at least in my mind, for us to try and work and tweak the optimization of how we use these therapies while we are continually working on propelling forward these new novel targets that are very disease specific in terms of addressing those driving biologic characteristics. So for instance, I guess I should say, and the other significant benefit from all of these optimized ongoing clinical trials, here I'm just highlighting PABMED-2 for obvious reasons, but all of these trials include tissue collection. And so the other significant advantage or value that we get from all these optimization clinical trials is that these are driving our research engine forward. Through these clinical trials, we're collecting tissue, we're collecting well-annotated clinical data and clinical outcomes, which is a huge wealth and resource for exploring additional novel targets in the future. So I would argue that continuing to support these optimized trials, even though they don't include some novel, sexy, drug or therapy, do add significant value to our research community and to our patients. So, but on that topic of new sexy targets, what are some of the ongoing clinical trials that are exploring these new targets? So again, this is a curated list. It's not comprehensive. Again, I've omitted, for the most part, phase 1 studies so that I could try and condense it onto one slide. But as you can see, it similarly includes large randomized studies as well as single-arm signal-finding studies. It includes practice-changing trials. A good example of that is at the top row, Samhita, phase 3 triple randomized arm, and the target is met, selecting savolitinib. But you can see a number of other interesting biologically important targets, such as NRF2, cyclin-dependent kinases, et cetera. The interesting thing to me, or one thing that I sort of took away when I was trying to compile this table, is that, when I think about new targets, we really have sort of disease-specific molecular pathway targets, again, for instance, NRF2, that are really tumor intrinsic for the most part. But then we also need to think about this barrage of new immune therapy targets, if you will, that are coming. Again, most of those didn't make the list because most of those are phase 1 trials. But you can see at the very last row an example of it's being initially in the first phase a TIGIT inhibitor in pediatric patients, but the second part includes all ages. So we are going to start having a barrage of immune therapy targeted clinical trials as well that are, again, I hope, significantly improving how we treat a lot of these cancers for our patients. So all of this gives me a tremendous amount of hope and optimism that we are going to simultaneously, through all of this effort, better understand each of these diseases, hopefully generate data to obtain these prognostic markers that we need, since we'll be studying the cancers in very specific diseases, as well as develop new therapies for our patients, which they demand and deserve. And thank you for your time.
Thank you. So we have about 4 minutes for questions. If you've got questions for our esteemed panel, please come to the mic and identify yourself.
Hi, Jim Rogarolas. So Ying-Bei, thank you. That was a very enlightening presentation. I think many of us, I certainly do, struggle with these concepts of the papillary tumors and the low grade and the high grade. And I think what pathology is done going to the molecular entities is terrific. And maybe it needs to be done farther, maybe taking the NF2 and the MET and the KEAP1 and further subdivide. And I realize that maybe from a pathological standpoint and a cost perspective, maybe you're waiting until we have clinical data that shows that influences management, but in reality, maybe the other way around. In other words, as you define these entities, you may be enabling the oncologist who is doing the trial to realize that there is a signal in a particular molecular group, which is something that we cannot do today. And, of course, this can, the other thing that this would help with is identify that subset of tumors for which we don't have molecular drivers, right? And maybe those are the ones that we need to go deeper. So something to think about. And so a question for Brad. So Brad, do you think that the theme that may be emerging, and I realize we have limited data, but with the limited data that exists, do you think the IO-IO versus IO-TKI may resemble what we see in clear cell? And what I mean by that is higher response rates potentially with IO-TKI, but perhaps not as durable benefit as we may see with IO-IO.
Yeah, there's a lot of other data for Nivo-IPI, and it's been relatively, I would say, disappointing compared to the clear cell situation. But it seems like there is certainly that chance for durable responses. So I would agree, similar to the clear cell, if you have a patient which needs a rapid response, you can favor a TKI-based approach. And if patient is understanding less response durability, I think nivo-ipi, there seems to be an emerging role for that across histologies.
Great.
But not renomedullary, because Pablos is here. I need to make sure I...
Dr. Stahler, we have less than a minute.
All right, then just a call to action. We need standardized reporting on path reports. We need standardized staining. We need you to tell us more about those tumors, because right now it's in most of the path reports, this is clear cell, end of the story. We can't work with that. It's not going to inform us whether the patients are going to be at risk of recurrence or not. We need any detailed information that we can get, and we need it in a standardized form above all that we're doing there.
So we do have the CAP standard template, so that I think many hospitals are following. But regarding the divergent histology, is sort of we practice at different settings, not those molecular markers, the very specific IHC test, not every hospital can run. So it's difficult to, say. So that's why we need a reference lab. We have the tertiary centers to handle some of the rare subtypes. But I agree. I think the molecular analysis gives us a lot of more information. So understand the morphology, what's behind the differences we observe, but we don't know why. So for the high grade, I think the unique challenges, many of the pathway initially are different drivers for different maybe subset, but in the high grade setting, they also converge. Like the NRF2, the NRF2, and the KEAP1, it's not mutually exclusive. You can see the NRF2 co-occur with FH. So they maybe become sensitive to both approaches to target them. So there's a lot of more, investigation needed for the high grade group. Yeah.
Difficult means possible, so I'm hopeful.
All right, thanks everybody for your attention in this session, and we're going to move right on to our special abstract session.